Improvement Foundation and the QI community bring you this month's QI webinar. Thank you for joining us. Hi everybody, welcome to the February QI community webinar. First broadcast 11th of February 2014. My name's Tony Lembke. I'm a GP in Austinville, Northern New South Wales, and today we'll be discussing care planning, a masterclass, part 1, with Ros Rolleston. Now, Ros, I'll ask you to introduce yourself, please.
Thanks, Tony. My name's Ros Rolleston and I'm a primary healthcare nurse in Nowra, New South Wales. I'm currently working with the Shoalhaven Council in Immunisation Outreach while I get my Masters underway and some research. But before that, I've worked in general practice here for about 4.5 years.
Good on you, Ros, and it's a great pleasure. Thank you very much for joining us this afternoon or this evening, depending on what state we're in. There's me in Austinville, and there's Ros down in beautiful Nowra. Good on you, Ros. Now we're talking about care planning. This is Masterclass 1, and Ros and I were talking about what we would include in this session, and this is part 1. This is mainly about the logistics of doing care planning, who's eligible, what item numbers there are, some of the procedures and logistics around arranging a systematic and proactive approach to care planning in general practice. And session 2, which will come later, and the term will be more about what actually goes on in the nurse consultation, the templates that we may like to use, how to organise other aspects of care planning. We'll see how we go with time, Ros. Is that what you were thinking, Ros?
Yep, absolutely, Tony, thanks.
So, Ros, I'll pass over to talk about what we're hoping people will get out of this session.
Thanks, Tony. Yeah, well, we're going to just review the MBS requirements. It always generates a bit of discussion and interest. We're planning to look at implementing the team-based approach to chronic disease management and some strategies about nurses leading the care planning process.
So we've got a little poll to start with, and I'll put this up on the screen. Now you can use your, if our attendees would be kind enough to answer the poll, you may be able to see it there. Have you been doing nurse-led care planning clinics in your practice? Yes or no? Unsure. So we can see now that nearly everybody has voted, and we'll have a look and see what the polls were. So 75% of us are already doing care planning in the practice, which is good. 17% no, and some perhaps not so sure. So, Ros, over to you. The chronic disease management process as you see it in the practice.
Thanks, Tony. I think it's really important when we start care planning process that we have a whole team meeting, including the GPs, the nurses, our reception staff, and our very important practice manager. Some of the things that we need to nut out as the team are, who is going to be responsible for identifying the patients that are going to have the care plans? What is the actual procedure that we're going to use to do it? What's the time allocation that we'll have for our nurses to be doing the care plan? Importantly, what's the template that we're going to use? And there's always lots of discussion around templates. And again, who's going to organise the recalls? Very important that we have the recall and reminder system happening.
Ros, there's some little tips you've picked up about how to improve the communications between the GPs and the practice nurses who are actually going to be doing the care planning, so they're all on the same page.
Yes, one of the frustrating things for nurses is when we sit down with a patient to do a care plan and we look and see, what is it that we're actually doing this for, and the past history doesn't have any information, or there's nothing in our, consult notes from the GPs to suggest what it is that they're trying to achieve from the care plan. So using either best practice or medical director, you can have autofills, and what I've worked with before is this one that we title CDMC for CDM consent. So you just type CDMC in and up will come all of this. I have discussed the care planning process with the patient who has agreed to have the care plan prepared with the nurse. I've updated the past history and medication list. Really important prompt for our GPs to have the file ready for the nurses. The GP can then write the illnesses that they want to be included on the care plan, the providers that they want to be included, and the review period that they're looking for. Great information that can be, when the GP sees the patient in the first instance, it can be a few weeks before they see the nurse, and this is a good way of getting the message across.
I can imagine, Ros, that there are times where you as a practice nurse see a patient who's been sent for a care plan. They don't know why they're there, you don't know why they're there or who they need to see, and this autofill process is to smooth that out in a systematic way.
Definitely, Tony, definitely. Sometimes as nurses we do struggle, but we, being resourceful, we'll look towards the medication list to give us an indication of what it is we're looking for. But the autofill just makes it nice and easy and smooth for everyone.
So I think it's important to note a few things at this point, Ros. One is that care planning and care coordination and chronic disease management has been a part of general practice for many, many years, well before the MBS EPC items became available. So we shouldn't see it as something totally different or alien to what we've been doing over the years. And that applies for nursing, as I'm sure you'll tell us. The other thing to note is that the actual process of writing down a care plan is only the first part of the journey that is the chronic disease management for that patient. So it's an important step, but it's the first step in an ongoing review process, and being systematic about that is where we get a lot of the success, I think, in chronic disease management. But nurses have been doing care planning for generations, Ros.
Yes, Tony, we have. We love our care plans. It's what we've grown up on, and we were always taught, by our instructors. We had to have every tiny little piece in the care plan that that patient might need. Comprehensive assessments is what we're used to doing. And it's often why nurses are looking towards wanting an hour because of the comprehensive needs assessment, remembering for a patient, time equals quality. The more time we spend with them at our appointments, the more they feel that they're getting a quality service and their needs are being met. One of the other good things about the 1 hour appointments as well is that for us as nurses, it gives us those few minutes to look through the whole file, to read the GP notes and specialist reports, pathology, go through everything. And that helps us with our self-education and connecting a bit more with our GPs as well.
1 hour is a good time for a nurse for the first time they've met a patient when they're preparing a care plan.
Yes. Another thing that, Tony, if we have the hour allocation that's really important from the whole practice point of view is that it gives us inbuilt flexibility. So we've got the time to do the flu vaccination and the pneumovax. We've also got time to, go and help the treatment room when they go into overload at times. Often the GP will want on the days a patient that's there in the practice and they really want the care plan done right here and now. When we've got appointments that are an hour, it gives us that flexibility to be able to help the whole practice as we go through the care planning process.
All right, and the care planning process, nurses can build on their knowledge by when they see one patient they gain information that's useful the next time they see a patient with similar conditions.
Absolutely, Tony, and it's another reason that it's really important to have that time to look through the GP consult notes, to learn from there, look at the specialist reports as well.
So, Ros, you might talk to us a bit about some of the changes in eligibility for patients to go on a GP management plan or a team care arrangement.
Yeah, thanks, Tony. We all know, I'm sure, that for a person to have a care plan, they need to have a chronic illness or a terminal illness that will be present for around about 6 months or more. But less known was some subtle changes to the MBS in 2002. And the changes came about when MBS told us what it was we could do, but our clinical guidelines differed in what we should do for our patients. So Medicare came up with the decision that for a patient to have a care plan, it was the clinical decision of the GP if that patient would benefit from a care plan. So it just kind of opened the path a bit, and in particular for people with mental health illness, people with reduced capacity to self-care. So we look at, enduring mental health illness that we may have done the mental health care plan on. We haven't looked at them in that whole picture, and we bring them over to the chronic disease management, and we can get them to see the dietitian. They can go and see the podiatrist. Really, really important for people with long-term mental illness to see the podiatrist about their feet. They can go and see the exercise physiologist if that were going to be of benefit, off to the optometrist to have their eyes checked. Lots of things that we can do for this group. It also tells us that people with intellectual or physical disabilities are also eligible to have a care plan due to their reduced capacity to self-care. Often this group of patients also require the care plan for access to the other services such as the OT, speech pathologist, physiotherapist. And for us, looking at chronic disease, it also opened the doors for all of those people that were sitting there not really diagnosed with the chronic disease as yet, but we knew that they were going to get there. So this is people with obesity, hypertension, lipids, high glucose, all of these kind of people that we, used to say, well, we can't do it, but we wish we could because, gee, they could benefit now. And these people can, in some instances, have the care plan. The important factor that Medicare put was that the GP must satisfy themselves that their colleague would agree to this patient having a care plan.
So that's a really interesting change, isn't it? It's a matter of what the man on the street GP would think was reasonable. I've been at a meeting where a senior GP complained that one of his patients saw a skin cancer clinic and had a care plan done for the management of solar keratosis. So the whole room groaned, so it would appear that that wouldn't perhaps meet the standard of what the common GP would think was appropriate.
Yes, we do hear of instances, I think, Tony, where we don't feel that this has really been a good care plan, or one that really, what is the patient gaining from the care plan? What is the benefit to the patient?
So, tell us about, if you would, what happens in residential aged care facilities.
Yes, residential aged care facilities, they have separate kind of section. We all know that those that are in high care, the facility is actually responsible for doing the care plan, so we can't do 72123s, but what we do is we review or contribute to their care plan. That item number is a 731, specifically for residential aged care facility. And I think it brings back around the $69 and can be done 4 times a year. The challenge I find with the nursing homes is locating the care plan. Very challenging when you actually ask, can I have a look? But really important that even if you don't get to see what it is that they've done, you still enter into the patient notes, care plan contribution, MBS item 731, and you give your instructions along with that, which can be things like, we do want them to have their blood pressure checked once a month and their blood glucose checked once a month. We might even want them weighed regularly as well.
Oh, thanks, Ros. I wasn't aware of our ability to contribute to care plans in aged care facilities. What about at hospital discharge?
So hospital discharge is one that is difficult to actually get Medicare to agree to, although it is their criteria. So again, this item number here is the 729. It's a $69 one as well, and it's a contribution to somebody else's care plan. So if you've got your very complex patient in hospital, they're seeing the discharge planner because they've got enormous needs when they're going home, then, you know, we can contribute to that care plan. Sometimes what we've done here in the Shoalhaven, the practice nurse has actually gone up to the hospital to see the patient up there, talk with the discharge planner and help get everything organised. But importantly, I think about the hospital discharge, Tony, it's good to know that you know, if you've got a very complex patient that's been discharged from hospital, they've now come to see you in the rooms, they've had a whole range of new treatments and everything put in, then this comes under exceptional circumstances, which we'll talk about in a minute.
So when a patient's eligible for a care plan, then we need to decide on their review periods. How often can we do both the care plan and the review?
Again, we need to look at our clinical guidelines here. Medicare tell us to do a new care plan every 2 years and review every 6 months, but our RACGP clinical guidelines tell us that best practice is to do a new care plan every 12 months and to review these care plans every 3 months. Really important stuff because we've built the relationship and it's the ongoing, as you said earlier, and continuity of care that's really important in keeping connected with our patients to keep them on track to achieve their goals.
12 months for care plans is reasonable, 3 monthly review for those people who require it, and then sometimes there are exceptional circumstances in which you can do it more often than that.
Yes, exceptional circumstances are another area where it's misunderstood, and these become available when the patient has had a change in their treatment plan, change in their care providers, significant changes to what their needs are. In these instances, we can do the 72123 within a 12-month period, and we can also do reviews more often. So you wouldn't have exceptional circumstances numerous times in a year, but certainly we can use that when it becomes available. Now, one area that is often misunderstood is when you have a new patient to your practice. So we don't do care plans on the first and second appointment, but once we've got the patient, they've been with us for a while now, they may have had a care plan at their previous practice within the last 3 months or so, but because we've got a whole new treatment team now on board, we can do a whole new care plan in our new practice, the whole 72123. The most important thing about exceptional circumstances is that you must annotate the billing. It must say change in treatment or change in care providers.
Okay, thanks, Ros. I just put this slide in, Ros. You haven't seen this one, but this is how, I was just going to demonstrate how we organise a care plan day. We do whole sessions just doing care plans and care plans review in our practice. Donna's our care manager, and I'm the struggling GP. So first appointments are half an hour with Donna and half an hour with me. That's Elmo and Kermit there. And then review appointments every 3 months, 15-minute appointments with Donna and 15 minutes with me, and we stagger the bookings. So Big Bird's told to come in at 11, at which time it sees Donna and he'll see me at 11:15. So this is how we, I just thought I'd throw that in, that's how we stagger our care plan days. We like to do them in 1 day a week. We do our reviews, and we would see most patients every 3 months or every 6 months, depending on their clinical need. When they leave the surgery, they're booked for their next appointment, and it saves a lot of trouble with recalls and reminders if they can book on the way out. We do just say 3 months or 6 months. That's the way we organise our days in our clinic. So over to you, Ros, again. So requirements for doing a care plan.
Important, we can always look, as the tag down the bottom here, the MBS online. It's one of the best things that you can have. Look for the item number and then also click on there'll be an A23 or something, the more information that you can get. But the requirements are we must document the consent. We must have a written plan. The goals that we set must be agreed to by the patient. We need to have 2 ongoing providers. Important to realise here it's ongoing providers. If you were to send a patient to see an exercise physiologist for a one-off appointment, then that is not an ongoing provider, so they can't be a member. You can have them on your care plan, but they don't qualify as a member of your TCA. And important here also to remember that it's only one other doctor besides the GP for the TCA. The other important bit is that we have to collaborate with our other providers.
Ros, perhaps you could tell us a little bit more about some of the systems you've seen developed by practices so that they can demonstrate that they've collaborated with other providers as required to claim a team care arrangement.
Yes, thanks Tony. I think one of the more commonly used ones is a fax that's sent to the other providers, and they circle yes, no, that they're going to be involved, sign it and fax it back. This is an easy system in that it can then, be scanned into the patient file, but using secure messaging is becoming more and more readily available and more in use. Takes out that need for faxes and scans. Some other systems that I've seen is where the care plan is with the patient and taken to the other providers, and the other providers actually sign off against their name on the team care arrangement.
Okay, thanks Ros. And then there are a number of providers that perhaps we haven't thought about who contribute or become part of a patient's care team. I think it's really important that we as the GP team and our patients and their families can identify all the people that are involved in their care, and often the time when we're writing up a team care arrangement is the only time really where we have that chance to identify everyone they're seeing, including their dentist and their pharmacist. So Ros, you've thought a lot about who are appropriate members of a patient's integrated care team.
Yes, thanks Tony, and it is, we've got a comprehensive list here, but I'm sure others can come up with some more. But the clinical nurse consultants, not just the diabetes educator, but the heart failure nurse, the COPD nurse, they also qualify to be on the team care arrangement. We know dietitians, podiatrists, exercise physiologists and physios, they're our common ones. Osteopaths are another one. We've got quite a few chiropractors in our area, so there are a group of patients who prefer to see the chiropractor. But just a note here for the nurses, please check with the GP first on whether or not they're happy to refer to a chiropractor, because often it's not the case. So we don't want to write a referral and then have it upset the GP and the patient. We look at that beforehand. Occupational therapists, as we've mentioned before, speech pathologists. Dentists are really important. I know we do not have the dental scheme anymore, but a lot of our patients with chronic illness are also on the healthcare card or pensions, and they need to get on the community dentist waiting list. The waiting list in our area blew out to 2 years, but the community dentist is actually able to give vouchers to get people back into the private dental service. So please, just because we don't have that scheme, don't think about a person's teeth. And our pharmacists, every patient, please find out who their pharmacist is. Encourage them to have one pharmacist only that they can build a relationship with. Sometimes from our care plan is where we identify that the patient would need the HMR referral. And of course we've got our specialist doctors as well. sometimes when we're going through and looking at the physical needs of a patient, we realise that there's possibly things going on at home for this person's mobility that could be dangerous, and we might want to do the ACAT referral as well.
So it's worth noting, I think, Ros, that it's important to identify all the members of a patient's care team, but for the Medicare purposes, which is secondary, we need to have at least 2 providers, so 2 ongoing providers. So the ACAT team may be only a short-term, not have an ongoing relationship with the patient, but they're still one of the providers. So is that right, Ros? Of all our long list of people involved, we need at least 2 to satisfy the team care arrangements for Medicare.
That's correct, Tony. We need 2 to satisfy. What I find is with sometimes the nurses, the nurse consultants at community health or ACAT, they get left off the team care arrangements because they don't actually have to get that TCA referral as such, and it makes them feel left out when they're important players in this person's health care.
Yes, thanks, Ros, for reminding us that it's not just about how we can identify the 3 providers to be part of a team care arrangement or identifying who can access the special Medicare allied health numbers, but it's about identifying all those who are members of a patient's particular care team and making it work as an integrated unit. Well, so it's about the CDM folder. And do they have to be blue? Is there any law in Medicare that says the folders have to be blue?
Well, it's interesting. The CDM folder really brings out the best in our practice managers, Tony, I find. So while you guys have blue, I've worked in a practice where they were green because that's the colour that's associated with the practice. There are also practices that use red, so we can have any colour that we choose. It's really interesting when husband and wife teams say, you know, can we have different coloured folders please, so we know which one's which. And that actually is telling us that we're actually engaging with these patients. But what's really important about the folder, what I love about the folder, is that, you know, we're talking about a display folder, one that you'd use for your CV, and you put all of the information in the folder, and you can put the pathology and the ECG and everything, and you actually hand that to the patient, and you see their shoulders go back and a smile on their face, and you've engaged them right there and then. You've brought them in as a team, as a part of the team of their healthcare providers. They feel then that they actually have a role in their care. They feel that they've got responsibility and that they've become a person that can have some choice. Nurses, we often like to put the information sheets about their illnesses in those folders as well. And the other beauty is, once you've got the care plan in the folder and you've instructed the patient that they must take it to every health-related appointment, including when they come back and see you, because that's the evidence that they're doing it. This then becomes your communication with all the other team members. So you don't have to print off multiple copies of the care plan and be sending that off to many people.
Well, I was going to say, Ros, in our practice, we consider the folder to be the care plan. The folder is the care plan.
Yes, Tony, the folder is the care plan, and this is certainly what the patients feel. They feel ownership over their care plan when we've given it to them in a display folder. What I really love is when the next day I get the phone call from the patient who rings me up to tell me that I've made a spelling mistake on page 3, column 2. And I know that that means that patient's actually gone home and had a look at their folder. Sometimes I put little tags on them and say, this is the page I want you to show the specialist. That might be their ECG. But it's beautiful when they ring you up the next day to tell you about the mistakes you've made.
Yes, and certainly part of the role of care planning is improving our patients' understanding of our illness and help them do the real work, which they do at home, and having them control their communication tool and have access to all their results and goals and targets and correspondence. It's a real boon, we find, in chronic disease management.
Definitely, Tony, and they love to look at what pathology was earlier in the year, to what it is now, and they're very proud of the results that they achieve by seeing this concrete black and white evidence of what they're doing.
It's amazing that they rarely lose the folders in my experience. What about you, Ros? What have you found?
Exactly the same, Tony. They do not lose the folders because they like them so much. They're quite proud of their folders and they show their family and friends. We have patients that take them up to the emergency department when they go to hospital. We always get a lot of good response from the ED staff when they see the folders.
Great. Now, Ros, after the practice nurse has seen, or the care planning nurse has seen the patient, practices have different strategies for the general practitioner to contribute to that consultation. How do you like to organise that?
What I generally advocate for, Tony, is for the GP to join the nurse and the patient in the nurse's consult room. This is really challenging for our reception staff to get the time frames worked out. Also for the nurses, you know, because we all have the occasional GP that will run late all the time. Difficult to time frame, but if we can do this, it is just wonderful. The nurse hands over with the GP, prompts the GP who comes into the discussion. You can lead into the questions that the patient wants to ask of the GP, and while the GP is sitting there, you know, maybe they need to print some scripts, and this is when I put all of the rest of the care plan in the folder. We get to talk about, the nurse learns, the patient learns, and the GP gets to pat everybody on the back for the good job that they're doing. The other thing I like about this is that when the GP comes into the nurse's room, patients don't often feel that they will go into other questions about all different things that they would with the GP if they went in to see them in their own room. And we all know that kind of grey area of, can you claim a 23 when you claim a 72123?
We found, Ros, that the nurses spent so much time waiting for the doctor to pop in at the end of the consultation if it wasn't booked, and the doctors found it disruptive if it wasn't planned ahead that they would be seeing that care plan patient. That's why we changed our booking to one following the other in this staggered approach we had before. We still have a handover.
Yes, and there are other ways for the handover as well. I know some practices the nurse just writes on a little post-it note, you know, what's happened, and if their blood pressure may be high, something that the GP needs to pay more attention to today, what referrals they've done. But don't forget the messenger in medical director and the F8 messages in best practice. It just takes a few seconds to send a quick message off to the GP, comes up on their screen, and they know to have a quick look at that before they bring the patient in. So there are alternates to the GP coming in for the handover.
Some of the other things that happen in the care planning consultation, including the follow-up, you've listed some of them there. Do you want to talk to us about those?
Yes, I generally advocate that once we've done a care plan, we've established this relationship, I generally suggest that we look at seeing these people every month on a regular appointment. Before they leave, make the appointment for their next consult. They can come in remembering that we have 10997s once we've done a care plan, 5 a year, but as you said at the beginning, Tony, the care plan is just step one in the chronic disease management process. There's lots of other things that we can do. We may need to do an ECG, we may need to do spirometry or the ABIs, might need to be monitoring somebody's blood pressure while we're changing medication, INRs, how they're going with their blood glucose. Often it's really about the ongoing health coaching, ongoing goal evaluation, helping people keep on track, might be weight and activity monitoring, lots of vaccinations we might need to do besides the flu and pneumovax. Remember, in New South Wales, ever since last year, Hep B is free to the majority of people, so we do have a lot of people out there that have not been vaccinated for Hep B in our adult populations. We might also need to do the mental health care plan, diabetes annual cycle of care, or the asthma annual cycle of care. So there's lots of ongoing work, and if we can bring the patient back to see the same nurse and the same GP, we've got that continuity of care, we've got expert collaborative practice happening here, and that leads to improved patient outcomes.
Yes, I'm sure that the triangle that's formed between a patient's regular GP, their regular care plan nurse at the practice, and the patients themselves is a really important predictor of how good their chronic disease management is going to be. And the more we use our practice nurses as part of our practice team, I think the better the results that we're seeing. We've had some questions, Ros, about some of the item numbers. Do you want to explain the 10997, 10987, and we know the 732s, I think.
Yep. So the 10997 is the follow-up item number from a care plan, and that's for the practice nurse to see the patient for anything related to the care plan, whether it's vaccination, education, blood pressure monitoring, anything that we're doing. And it actually brings, you know, it's only a minuscule amount of money. It's only $12 that we get remunerated for it. However, that still adds to the whole practice. So this is why I suggest that we look at seeing our patients regularly every month. We do one care plan, we do 4 reviews, and then we've got 5 10997s. So we've got actually 10 funded appointments already without even thinking about whether they might need the ECG and when they need to come for scripts. So the 10997 is a really important one, and nurses often feel ownership over the 10997. They like to be the one that puts that up because they're proud of what they've done and back to the care. One of the important points about the 10997 is that the GP does not have to be present for these bills. The GP does not even have to be in practice at the same time. So the nurse can actually claim independent. I'm not suggesting that the GP doesn't need to see the patient as well when they're there, because as we said, collaborative team-based care is the ideal best practice that we need to help our patients. But if the GP for some is out on an urgent call, the nurse can still bill the item. Now the 10997 is another important one, and this one actually comes once a patient, an Indigenous patient, has had their health assessment. Once they've had health assessment, there are then 10 funded appointments to see the nurse or the Aboriginal health worker. Now 10998 is actually worth $24 an hour, and it can be independent of the GP. What I want everybody to realise is that if we have an Indigenous patient that had their health assessment 715, they've also had their 72123, that means there's 15 funded appointments to see the practice nurse per year. This is really, really important that we use these, because we know our Indigenous patients really need our help, and keeping connected with what's going to stay on track, gain the education and understand to be able to improve their health.
Ros, one of the questions that we received as a pre-question was about whether nurses are able to claim a 10997 at the same time as they may be contributing to a 721 or a 723 or a review item number.
Yeah, so Medicare does allow the 10997 to be claimed with the 72123 or indeed the 732s. However, I do generally advocate that we hang on to those for those ongoing appointments that we're going to be seeing. Things like if you wanted to do, we'll just use an ECG for instance because it's easy. If, you know, we might need to, for clinical indication or to have a routine ECG on file, and an ECG is worth around the $35, and then the GP adds the 23, so it brings it up to around about the $70 mark. If we then add the 10997 in, we've got it up to around the $80 mark. then, you know, if this is an Indigenous patient, we can claim the 10987. All of a sudden, we're already over $100. And then if we add the bulk billing 10991s in on top of that, an ECG can actually, you know, that's the instance. And I know I'm talking outside of the quality patient-centred care here, but the business model is really important in general practice, but an ECG worth $35 can be turned into $140 by keeping those 10997s
Right.
to use as we go through the year.
One of the things, Ros, is people, I think the government tells me that a lot of 721s are done and 723s, but very few 732s. And certainly the review process as part of the care planning, I think, is just as important as the initial consultation. And I'm surprised that practices don't do 732s. Have you any thoughts on that?
It goes back again to the beginning, what we were saying, Tony. We need the practice process. We need to have somebody identified that's responsible for the recalls and reminders. I've worked where practices where the nurses that do the care plans are responsible, but where it worked brilliantly was where each GP in a practice actually had a receptionist allocated to their recalls and reminders. They also looked after their room and kept it stocked. This is where it really worked well, where the patients come back. I think it's all about the recall and reminders, and they get slipped by the way. If from the nurse's perspective, once a month they send out a whole pile of recall and reminders, then they don't know what patients actually ring and make the appointments. When the reception staff do it, they keep track of it much, much better, and it seems to work better. But it's, as you said, whatever we need to do for each individual practice to get the reviews happening is really, really important. We need to keep contact, we need to stay connected, we need to help our patients right across the whole year.
So we had a technical question coming about when we claim a 732 times 2 and when we claim a 732 times 1.
Definitely the 732, if we have done originally the GPMP and the TCA, so we've claimed the 721 and the 732, when we do a review of that care plan, it is 732 by 2. We are reviewing the GPMP and we are reviewing the TCA. So generally when a care plan is reviewed, we bill 732 times 2. Again, it's good to annotate this, not a duplicate service.
And you remind us there in that last point, Ros, that the most important member of the patient's care team is the patient themselves.
Absolutely, Tony, and keeping connected with them, keeping them on board, this is what's really important.
Of the role, Ros, of practice nurses acting as case managers in general practice is a fairly new one for many of our practice nurses, and you've identified some of the key features that a case manager would do as part of their work.
Yes, and it is a new role for nurses in general practice, and indeed the recent ATNA CPD survey, there was a request of nearly 50% of people wanted ongoing education in case management. But case management is where the nurse is the person that's got the ongoing contact. They're doing the disease surveillance, making sure that the pathology's done, everything's happening. They're coordinating care. They might be having to ring up and make appointments, ring the patient to prompt them where to go. So when we do a care plan as a practice nurse, we're working under the direction and supervision of the GP, but when we're working as a case manager, we're also working independently of the GP. Once we become independent of the GP, the general practice nurse can be a TCA team member. Very important. The general practice nurse can be a TCA member if they are having an independent role such as case manager. really important for our rural areas where there might be a lack of ongoing providers around. You might have the specialist doctor that visits every 3 months, and you know there's not a lot of other people, but the nurse, if they're doing this close work with the patient, working independently, they can be the second provider on the team care arrangement.
Oh dear, well, that's a really useful point, and thank you for bringing that up. Now, there are more resources available for people who want to look further into some of the things you've talked about.
Yes, certainly. I think I strongly recommend the CVC program education to anybody, particularly nurses that are new into care planning process. It generally goes for a day. They bring in patients, you can have a bit of practice. We know that it's Flinders University that have done a lot. I mean, a lot of unis have done a lot with chronic disease management. Flinders managed the CVC program. Then Health Change Australia, they're a fantastic organisation, and that's all about health coaching and motivational interviewing. As I said earlier, MBS Online, make it your best friend, have it on your desktop. Whenever you've got a question in your head, just quickly open it up and have a quick look. The other place that I like and generally send people to is the patient-centred medical home webpage. Beautiful page, really talks about the team-based care that we do so well in general practice, really important guideline for what we do with our chronic disease management. And don't forget the RACGP, fantastic resources, great guidelines. We've got diabetes, chronic kidney disease, heart failure, lots of guidelines there. And when it comes to immunisation, of course, we need to look at the new immunisation handbook. It's going to take a while to get used to that one.
There was a question from David Guest about, Ros, for the 729 at the hospital discharge, does the GP have to physically attend the hospital?
No, the GP doesn't have to physically attend the hospital. In the instances where I've claimed this, I've gone up to the hospital to ensure everything's organised. They're discharged and they come down to the practice to see the GP that afternoon or the next day. Occasionally the GP might have to do a home visit. So the GP does have to see the patient, but it doesn't have to be in hospital.
Okay, so it can be after discharge.
Can be after discharge, but related to the discharge. But remember again, if we've got a complex patient and lots has changed, then we are really better to do the 72123 under exceptional circumstances.
Okie doke. Thanks, Ros. Brian, were there any other questions that you feel we should answer now?
We've got a good one here actually. So Sam Ryder from Blue Mountain says, aside from the HMR, what can pharmacists do for the care plan? She said that she had a pharmacist say that we never write anything and don't really know what's expected of them.
There's plenty of ways we could use pharmacists better, and part of that is just realising that they have more contacts with the patient than we do. Most patients, of 24 contacts have with the health system every year, 12 of those are with pharmacy, normally 3 or 4 with general practice. So it makes sense for us when we do a care plan review to keep the pharmacists up to date of our patients' current medication lists. So there's some similarity at least between what they're taking, what we think they're taking, what the pharmacist thinks they're taking. It would be nice if there was some similarity. And pharmacists have lots of skills that many of them would love to put into effect. I think that having a communication relationship with the pharmacist is something that we can all begin to work on. And the first step will need to come from us, which is writing to them, keeping them informed, seeking their input. Ros, do you have any experience with that?
Yes, the pharmacist is one of those ongoing providers. If we can explain to the patient the importance of having their main pharmacist, and generally our patients with chronic disease do have one, and we communicate with the pharmacist, they see them regularly every month, they're the key provider of education around the medications for the patients. Pharmacists, I think, at times even underestimate their role in chronic disease management, and sometimes we get the call from the pharmacist who says, Mrs. Joe was in this afternoon and she really didn't look very well. Do you think you might be able to give her a call? pharmacists are important and they are ongoing providers.
So Ros, I think our time is up. We'll leave it there for this session. And on behalf of all the 90-odd participants, I must say we thank you for your authoritative knowledge of care planning and reminding us that it's about patient care more than it is about Medicare item numbers. But the Medicare item numbers do allow us to put more resources into where they're needed. And I think if we're doing the work, and I know that our collaborative practices are, then we need to be sophisticated in claiming the item numbers to allow us to use these general practice team-based, particularly practice nurses, effectively and to fund it. And we're really proud of what the collaborative practices have taught us about general practice teams in the medical home. So Ros, we thank you very much. I hope that you'll be able to join us again in April for part 2, and we might go through some more of the framework of what makes up a good chronic disease consultation by a practice nurse and then by GPs, and perhaps look at some of your favourite templates that you like to use to help you in your care planning.
Thanks very much, Tony, and thanks everyone for listening. I've really enjoyed it, and definitely we'll be back in April.
Thank you, and look, I'd like to thank everyone for participating and attending. Thanks, Brian and the QI Community staff and team down at QI Community Central for facilitating this webinar. So thank you, Brian, thank you, Alison, thank you, Ros, and thank you, everybody. Good night.
Good night.